Go through this a little bit more rapidly, is on systemic and pulmonary hypertension. Some of this is a little bit of review, so I'm going to go over it a little more quickly, okay, and then we're going to go into the actual discussion about the antihypertensive drugs more carefully. The most common circulatory problem is still hypertension. It leads to multiple organ failure, and the definition of it is usually a systolic greater than 160 and a diastolic greater than 100. This is your actual normal pressures that you would tend to see, expected of less than 120, systolic less than 80. Pre-hypertensive patients are showing now that they're between the 120 to 140, 139, and then between 80 to 89 diastolic. And then stage 1 hypertension is the very common one that a lot of times doesn't get treated, and then it goes into stage 2 hypertension, which is much more significant, which then starts causing the end organ damage. Hypertension basically leads to several problems. One is it increases active load on the heart. As a consequence, it increases your myocardial wall tension. This leads to an increased myocardial oxygen demand, as well as development of left ventricular hypertrophy. Okay, over time, it will be the increased workload because of the increase in workload during the left ventricular isovolumetric contraction leads to eventually coronary insufficiency. And eventually this hypertrophy plus the insufficiency will lead to heart failure and may increase the risk for infarction and dysrhythmias to form. Blood pressure regulation as a consequence is very important. Okay? How this blood pressure is regulated is due to baroreceptor reflexes that are located in both the carotid and the aortic bodies. Okay? There's several, of course, vasoactive hormones besides just the sympathetic and the parasympathetic nervous system that controls your blood pressure. These are the long-term effects, which are the vasoactive hormones, which is renin and angiotensin, as well as aldosterone and catecholamines, such as epinephrine and norepinephrine. Remember your renin-angiotensin system, where angiotensinogen is converted by renin, which is released by the kidney, into angiotensin 1. Angiotensin 1 has no vasoconstrictive properties until it arrives to the lung, where it's converted by angiotensin-converting enzyme into angiotensin 2. The angiotensin 2 has the powerful effects of vasoconstricting, plus also has secondary activation of norepinephrine release. It also increases antidiuretic hormone, which increases your reabsorption of water to the kidney. It also increases sodium reabsorption, and aldosterone levels will begin to increase, which also leads to an increase in sodium reabsorption. This eventually leads to an increase in blood pressure. There's only 3 systems really to control vascular smooth muscle. Okay, is your sympathetic drive. Okay, remember, there's no parasympathetic drive here at all. Okay, so the only thing that really controls vascular smooth muscle are these 3 systems. The other 2 are the renin-angiotensin system and the vasopressin system, and literally goes from the most powerful to the least. Okay, so vasopressin, even though it's on this picture, it's generally on a scale of 1 to 2% of the overall control of blood pressure. The rest of it is 70% is regulated by sympathetics, and about 30% or 28% is regulated by the renin-angiotensin system. So it's really the majority of the pressure that we have regulation is due to sympathetic drive. Primary central hypertension has mostly unknown cause. It occurs in about 95% of our patients. Okay? Secondary hypertension, on the other hand, has a known cause. Most commonly, when you look at it, it's due to kidneys. It could be to vascular disease such as renal artery stenosis, okay? Or it could be induced diseases such as diabetic nephropathy. You can also have coarctation of the aorta, which then leads to a constriction above the renal arteries, which then acts almost like a renal artery stenosis. Hyperadrenocorticism, pheochromocytoma, which is tumors of the adrenal gland, and which leads to release of norepinephrine and epinephrine in high levels. You may also have primary aldosteronism, which then increases your aldosterone levels to very high levels, and as a consequence increases sodium reabsorption at very high rates. Treatment for most primary hypertension is usually that's really what the cause is. It's bad lifestyle, so losing weight, exercise, smoking cessation. Low sodium diet is also important. One of the things they found out recently is that sodium is actually perceived differently in individuals. Okay? Some people actually have more sodium receptors than others. As a consequence, some people have a much more higher tendency to take in more salt because they actually have insufficient receptors. So some people are going to be much more resistant to low sodium diets. Antihypertensive drugs are the next set of discussion, is where I'm going to talk a lot more detail, is on diuretics, angiotensin converting enzyme inhibitors, calcium channel blockers, vasodilators, and sympatholytics. This is your actual classification of your drugs. You can have your comorbid conditions that are associated with it and why you use it. If you've had post-myocardial infarction, a lot of people are placed on ACE inhibitors, aldosterone antagonists, and beta blockers. Patients that are in heart failure, you want to reduce your afterload, reduce your preload, okay, and increase the contractility if possible. So one of the things that you'll do is you give them ACE inhibitors, which are basically afterload reducers, okay, aldosterone antagonists, which prevents sodium reuptake, which then as a consequence drops your preload. And then you have angiotensin receptor blockers, which are very powerful, much more powerful than ACE inhibitors. Maybe they actually inhibit the action binding of angiotensin to receptor. Okay? These are really becoming a problem for us because they're too dang on powerful, and they're knocking out the angiotensin system completely on us. Beta blockers are also used not for the reason you think. And beta blockers are actually used to prevent remodeling of the heart. And we find that beta-1 receptor, if you actually bind to it and antagonize its action, you actually stop the remodeling of the heart, including dilation of the heart. And again, diuretics are basically to drop the preload. Beta blockers can actually induce heart failure because you can overdose the person on too much beta blocker activity and slow down the heart rate and basically cause a decrease in contractility enough that the person can go into heart failure. But if done appropriately, you prevent the actual heart remodeling, which is where the benefits of that drug is. High risk for coronary artery disease, ACE inhibitors, beta blockers, calcium channel blockers, and diuretics. Okay, so the patient is given calcium channel blockers that keep the heart rate under good control. It acts also sometimes as a vasodilator. The calcium channel blockers are very controversial as which one to use, in the sense that there's very different kinds of calcium channel blockers out there, so really there's still a lot of studies ongoing into what's the beneficial effects of calcium channel blockers overall. Diabetic patients have a high risk for having problems because they have silent ischemia, so they're basically like treating patients with coronary artery disease. So you have your ACE inhibitors, your beta blockers, your calcium channel blockers, and your diuretics. What they have also added is that they also have added the angiotensin receptor blockers, because these people have diabetic nephropathy, which ends up increasing the levels of production of renin-angiotensin, and as a consequence, these ARBs are used to sort of prevent that secondary effect. Chronic kidney therapy, again, ACE inhibitor has got to be done very carefully. The ARBs as well is used very carefully, but they're used now because of the overstimulation and production of too much renin during chronic renal disease. Patient with recurrent strokes prevention, ACE inhibitors seem to have worked, and diuretics may also be beneficial. Okay? Now you can actually break these down, and this is how I expect you to break them down. Now what I want you to do is, if you have your MindJet maps, okay, this is the basic idea. Okay? The major heading when using MindJet maps would be a diuretic. Okay? The other one would be adrenergic agonist, vasodilators, ACE inhibitors, angiotensin receptor blockers, calcium channel blockers. So that's your major heading, and everything after that would be your subheadings. Okay? And it's much more manageable if you know that all diuretics, okay, will basically cause some kind of electrolyte dysfunction. As a consequence, you should check your electrolytes prior to doing surgery, and all your diuretics are basically contraindicated for surgery. Okay? Dropping preload already in a situation where you're going to drop their preload with anesthetic agents means that these drugs are really not to be used prior to surgery. The drugs that you're looking at are thiazides, the loops, and the potassium-sparing diuretics, and they work in different locations. I will only ask you the generic name on the test, so you just have to know some of these. Okay? Do not memorize the trade names, because I won't ask you those, because on your boards you're not asked the trade names, you're only asked your generics. Okay? The adrenergic antagonists can be the beta blockers, the alpha blockers, the combined alpha and beta blockers, and centrally acting. Okay? We tend to have gone away from centrally acting, which are alpha-2 agonists such as clonidine, okay? And methyl-dopa, which is a central acting agent that mimics dopamine. Okay? You can also use vasodilators such as hydralazine, okay, which are direct-acting ACE inhibitors, okay, which all end in opril, okay, or pril, basically. Then you have the angiotensin receptor blockers, where they work basically by inhibiting the angiotensin 2 receptor from being bound by angiotensin 2. They all basically are called sartans, artans, if you look at them right here. So they all end in sartan. Okay? So that's how you memorize this stuff. Okay? Try to look at the nomenclature of the generic name at the end, because that usually will tell you what class of family it's in. Okay? And that's very helpful for exams as well as recognizing. The problem is when you look at the trade name, which is what they give you, in clinical, they have nothing in correlation. And that's the big issue, I think. I think we should never have any trade names and switch only to the generic names. That would make my life so much easier. Okay? The calcium channel blockers all end in lodipine, okay, or dipine, okay, depending on which kind of drug it is. Okay? Nicardipine is cardine. Okay? Nifedipine is Procardia, or Adalat, is the other name for it. And then Norvasc is amlodipine. Then you have the other forms of calcium channel blockers. There's two family members. There's the dihydropyridines and the non-dihydropyridines. Okay, the non-dihydropyridines are things like diltiazem as well as verapamil. Both diltiazem and verapamil tend to be more of a shotgun-specific drug. It tends to have a wider activity. Okay? Diltiazem, it has a little less activity. It tends to be more acting on the AV node and the peripheral vasculature. As a consequence, it has less of the peripheral vasodilation that you get with verapamil. Now, what do you do when you have somebody with hypertension? First thing is you try to make lifestyle modifications. That's really where the key should be at. And of course, you know how long a doctor spends with you doing a lifetime modification. He'll tell you, stop smoking, have a less stressful life, lose some weight, take less salt in, have a nice day. Out the door you go. Thank you. And here's your prescription pad. That's the way it goes. Okay, they have 5 minutes to see you, and unfortunately, because we have to see 50 patients a day. How is that improving our health care? I'm not sure. Okay? And the reason that docs have to do that is not that they want to, is that's clinical reality now. Okay? If you don't see enough people, you're not going to pay for your electric bills. And the payment's so low. You're going to make more money than most general practitioners that are out there right now with 15, 20 years practice. Just realize that right now. Okay? So the system is upside down, the way I look at it, but that's the way it is. You know, our job is important, yes, but the primary care physician is also the first person that sees a patient who prevents them from having disease. Our system is not set up that way. Our system is flipped up where we have the high earners are the people that are doing all the procedures. You know, I realized that. I wasn't going to be a family practitioner. I did family practice for about 4 months one time as part of my rotation. It was really amazing. I'd already done actually it was like 4 weeks as part of my internal medicine rotation. We had to go out. So I'd already done my anesthesia for my first 3 months of anesthesia. So I'd already learned how to intubate, put in IVs, and all that stuff. And I was a resident. So I had a patient come in, and the patient coded right in front of us in the actual room. And I intubated the patient, and the paramedics got there and got the IV started, and we resuscitated the patient, got him back before we actually got him back on the truck. So we transported him on the truck, and as walking back in the office, I'm going like, wow, we saved that guy's life. So I walk into the next room to get to see the next patient. And this patient that I'm seeing saw us walking out on the stretcher with this patient. We were doing CPR at the time. And she looks at me and she says, "Doctor, you made me wait 20 minutes. You're late." I'm going, what reality are you in? You know? So that's when I said to myself, you know what, that's all people care about. They think like we're McDonald's. You know, this is not the area where I want to be. So I went into it. I was very happy doing anesthesia because realizing that I had to see 50 patients the rest of my life every day just didn't seem to make me happy. Okay? So again, these guys are first-line docs or first-line practitioners. It's a very difficult area to work in. So, thank the gods that you're in anesthesia. Okay. Initial drug choices is without compelling indications or with compelling indications. Okay. You have stage 1 hypertension. Okay. You can use the thiazide diuretics, the most common, and you may consider ACE inhibitors or angiotensin receptor blockers, or beta blockers, or calcium channel blockers. So this is a nice way of actually making sure that you're following some form of protocol. Most doctors and most nurse practitioners that are doing this kind of work have their protocol set up, and they're told that this is what they're going to do. Now, protocols are dependent on population. Okay? So you will notice that when you go to different locations, different patients are given different drugs. It isn't that the drugs are cheaper, okay? And that's not really most of the primary choices that most people make, is that most people know enough that some drugs work for certain populations that are better than others. And that's why those drugs are chosen. Management for these people is make sure you preoperatively evaluate them. Make sure that your induction goes smoothly, because these people tend to precipitously drop their blood pressure on induction. You can have a blood pressure of 220 over 110, and as soon as you put them to sleep, their blood pressure is 60. The reason that is the case is 90% of the time they're preload reduced. And then you give them the vasodilator, and that also preload reduces them more, and then you're really in trouble. Okay? So be prepared with somebody with chronic hypertension that they're going to need more volume and fluid. So make sure that you have a good IV before you start. Is the blood pressure adequately controlled? Okay. Medications that you're going to be watching for, and look for organ dysfunction. Determine the adequacy of blood pressure control. In other words, make sure the blood pressure is not out of control. You have a diastolic pressure above 110, really reconsider doing the case and really pretty much cancel it. Really, the key is to maintain a diastolic pressure less than 110. If you do it below that, there's really no evidence of post-cardiac complications. If poorly controlled, there's an increased risk of, when you're doing certain procedures, of developing strokes, and a prior MI also increases the risk of reinfarction. Some patients tell you that they have white coat syndrome, that they're really afraid of you, and that's why they are sort of hypertensive. And the Versed seems to work, but believe it or not, that's not a benign process. Most of these people are type A personalities that you're dealing with, and they're already sympathetically mediated. Okay, so when you put them to sleep and you intubate them, their blood pressure is all over the place. These people also have an increased risk for developing myocardial ischemia and increased risk of intraoperative vasodilators to be used. I can tell you personally that if you use an intraoperative vasodilator, you're permitting malpractice. I'm making that very obvious statement. Okay? Please, please, please never give an antihypertensive in the operating room unless you discuss it with the attending of the CRNA that's with you. Okay? Because 90% of the time is because you're not giving an anesthetic. Okay? I'll never forget this. Okay? I got called in for a consultation one time when I was a long time ago when I was a resident. I was a senior resident. And the people that were in the room, both an attending and the student resident at that point, were wondering why the blood pressure wasn't coming down, and that they were considering giving antihypertensives. They actually had called me to go get a nitroglycerin drip, a nitroprusside drip. So I was bringing nitroprusside with me. So I walked in the room, and they've got the vaporizer set at 4% on isoflurane, nitrous at 70%, okay, which is, thank God they did that. Okay? And the blood pressure was 170 over 80, and the person had no twitches. Okay, so completely paralyzed, but pretty high doses of anesthetic, and the blood pressure is still skyrocketing up there. So they're thinking pheochromocytoma, something really bad's going on here, possible malignant hyperthyroidism. So there's a whole discussion going on between that. Okay? In those days, we didn't have analyzers. So I'd look over, and I'd go, hey guys, why don't you fill that vaporizer with something? They had no drug in the vaporizer. Okay, the only thing that kept that person asleep was the nitrous oxide, thank God for that. Okay, but that's the first thing I'm telling you. That's where people have awareness. Okay? And then they treat the pressure with antihypertensive because they're thinking they're delivering enough anesthetic, when in reality they're not. Okay, so make sure that before you even give intraoperative vasodilators, you have absolute confirmation that there's a reason to give it. Okay? Now, the other reason also is that I don't let anybody give vasodilators unless they do one thing. Put a BIS. Put a BIS on the patient. Okay? The BIS is basically monitors the EEG activity of the brain. Okay? If the BIS number is low, then I would tell you, okay, you're giving enough anesthesia, so now you've got to look at other sources. So maybe that person does have pheochromocytoma. Maybe that person has malignant hyperthyroidism. Okay? So you got to look at other sources at that point. Okay? But then you consider also giving the vasodilators. Okay? But if you have a high number, then that person is resistant to the drugs that you're giving, and you may actually have somebody with awareness, and that's why their blood pressure is high. Okay? Complications of the drugs, I expect you to know. Partly covered last semester, but I expect you to still continue knowing this stuff. Thiazide diuretics cause hypokalemia and hypomagnesemia, and they have also decreased lithium clearance. Okay? Potassium-sparing diuretics basically block things, and as a consequence cause hyperkalemia, hyponatremia, and megaloblastic anemia. And this is the ACE inhibitor complication, which we talked about before, which is angioedema. ACE inhibitors may also cause hyperkalemia. ACE inhibitors basically have they basically block, usually most people are already on sympathetic system blockers from the general anesthesia, and then the renin-angiotensin system, you take the ACE inhibitors and knock that out. So now you're left with only vasopressin that controls your vascular smooth muscle. So these people are really going to be symptomatic when you put them under general anesthesia. It increases the risk that hemodynamic instability and hypotension will occur during anesthesia. So ACE inhibitors are not a joke. The thing is that some people are still recommending that you give ACE inhibitors. A lot of people are now beginning to second think that, okay, because they're starting to see too many complications, especially when they're telling you that if your blood pressure drops 30% below baseline, that you have an increased risk of developing myocardial ischemia. So where do you actually keep that person at? And that's a big question. Well, the mechanism is a blunt autonomic response by induction of the anesthetic. You blunt the actual renin-angiotensin system by the ACE inhibitor or the ACE angiotensin receptor blocker. And the remaining system to support the blood pressure, of course, is only the vasopressin, which is likely to be volume dependent. It may also decrease cardiac output by attenuating the venoconstrictive effects of angiotensin on the capacitance vessels, and which decreases your venous return. The surgical procedure may also involve some major fluid shifts. As a consequence, you have to be very careful, and it's very difficult to reverse the effects of ACE inhibitors. It may be more prudent to discontinue ACE inhibitors 24 to 48 hours preoperatively in patients at high risk for intraoperative hypovolemia and hypertension. The major disadvantage of this drug is potential loss of blood pressure control in the sense that you get hypertensive responses. Okay, so that's the downside to it. Okay. Angiotensin receptor blockers prevent angiotensin II from binding to its receptor. It increases the potential for hypotension. It may be refractory to conventional vasoconstrictors such as ephedrine and phenylephrine, and necessitates the use of vasopressin or one of its analogs. So that, again, I'm telling you, you don't want to be using vasopressin. That's not a joke drug. So, but if you have to now, that's one of the things that we're actually having to pull out. So it's not recommended. It's recommended that ARBs be discontinued on the day before surgery. So we're actually now beginning to stop giving these drugs now. If you'd read this literature before, they would tell you to continue all these antihypertensives until recently when we're starting to see a lot of problems with it. Complications also from antihypertensives from beta blockers is they can cause excessive bradycardia, okay, cause bronchospasm, and they can also mask hypoglycemia. Although it doesn't really matter under general anesthesia, hypoglycemia will be masked anyways. Calcium channel blockers can also cause complete AV node dysfunction, causing severe bradycardias. Most of the time, tachycardias are what you're treating with calcium channel blockers. The only reason that you'd go into a tachydysrhythmia is somebody who has WPW, and that's why it's inappropriate to use calcium channel blockers in that person. May also induce complete heart block, which is also an issue. You can reverse a lot of these effects by giving calcium, ionized calcium IV. So that's one thing to consider. Clonidine is an alpha-2 agonist. Okay, is not an antagonist; it's an agonist. Okay, so you have to ask yourself, why is it an agonist? Well, alpha-2 is found in the presynaptic terminal, presynaptic junction, and basically inhibits the release of norepinephrine from the actual presynaptic terminal. Okay, So clonidine basically is an agonist that inhibits norepinephrine levels to be released into the atrial cleft. The problem with it is that if you discontinue clonidine, all those excess vacuoles full of norepinephrine now have been accumulating, so you get a severe rebound hypertension as a consequence. The other bad thing about clonidine, because it also suppresses the alpha-2 and suppresses the norepinephrine release, it acts as a sedative. Okay, it's like taking somebody who needs high levels of norepinephrine to keep them awake, and you're shutting that down, and basically makes you sedated. So it's a very powerful agent, and because that in older people, it can cause significant sedation that can last up to a week. Hydralazine can cause lupus-like syndrome and fever. Look for other forms of organ dysfunction. Induction of anesthesia for hypertension is the exaggerated blood pressure response. Of course, perform short duration laryngoscopy. Avoid the ketamine. Things that can ameliorate the hypertensive response on induction could be the narcotics, although to do that is requiring 50 mics per kilo. So if you have a 100-kilogram patient, you're looking at 100 cc's of fentanyl. That's a pretty big dose. So of course that's not going to work, okay, for the normal patient. So really narcotics preoperatively before you do induction is worthless. Beta blockers is really the better way of doing it. Volatile anesthetics have also been very helpful to do it, but you have to get to a MAC of 1.5, and that doesn't take, that takes several minutes. You administer the volatile anesthetics to control blood pressure, monitor for ischemia, and intraoperatively watch for hypertension. Most of the time you're dealing with hypotension, not hypertension, when you have all these drugs on board. Postoperatively, you really have to anticipate hypertension because everybody develops hypercarbia. Okay? So I've never seen anybody develop hypotension in recovery room unless they're bleeding. Okay? Or the other reason would be, another reason for hypotension and bradycardia would be what? Adrenal crisis. Okay? Somebody who has not enough steroids on board, corticosteroids on board. Okay? They'll actually get bradycardic and hypotensive. Okay? So shock states are usually from low volume states. So most people, when they hit recovery room, they should be hypertensive. That's the norm. Okay, so we tend to give the antihypertensive drugs at that point. Hypertensive crisis is considered a definition of a greater than blood pressure of 180 over 120, and with a diastolic greater than 130 at times. Okay? Hypertensive emergency is associated with end organ dysfunction and eventually end organ damage. Okay? Cause of hypertensive crisis is all these different sources. Okay? One is basically essential hypertension that goes out of control, renal vascular hypertension. Withdrawal medication, especially of clonidine. Okay? Drug ingestion such as cocaine, eclampsia or preeclampsia. Head injury patients can also severe forms of hypertensive crisis. Pheochromocytoma has a 90% mortality rate if you go in there unknowing it, so it's not one of the ones you want to walk into. And this is basically all the different agents that you can use to help control this. I want you to sort of go over this in your own mind to make sure that you understand some of the reasons why they're giving the certain drugs that they're giving. Treatment of hypertensive crisis depends on the etiology, but really the first thing you do is you put an A-line followed by putting nitroprusside. But nitroprusside is not always the best choice depending on the cause of the hypertensive crisis. If you have somebody with central nervous system dysfunction, it could be that they're having a massive stroke, and that's why they're having elevation in intracranial pressure. So nitroprusside may be a temporizing drug to consider, but that person may really need to go to the operating room to decompress them. Next point is on primary pulmonary hypertension, also considered idiopathic pulmonary arterial hypertension. The good thing is it's a rare disease. Okay, basically in instances 1 or 2 cases per million people in the general population. It tends to be genetics, which is as an autosomal dominant inheritance. The median period of survival after diagnosis is 2.8 years, so it's not something good. It's basically progressive right ventricular failure. Perioperative risk is RV failure in these people, hypoxemia. They don't tolerate nitrous oxide very well, which causes some pulmonary vasoconstriction to take place. These people have very high PA pressures. The mean PA pressure is greater than 25 millimeters at rest or higher with exercise. Okay, these people don't have left-sided failure. It's basically right-sided heart failure. Pulmonary arterial hypertension can be idiopathic, familiar, or associated with collagen vascular disorders, okay, or also associated with significant venous or capillary involvement. Okay. Pulmonary hypertension with left ventricular heart disease, okay, is basically left-sided atrial or ventricular heart disease with eventually causing pulmonary hypertension. That is basically CHF. Okay. Pulmonary hypertension associated with lung disease, things like COPD, interstitial fibrosis, sleep disorder, breathing where you have chronic CO2 retention, or chronic exposure to high altitude, all may induce pulmonary hypertension. Some of these are more reversible, unless, of course, you're going into COPD where it's not reversible. If you have a sleep disorder breathing, then if you reverse a sleep disorder and like doing uvulectomy on somebody or doing removal of tonsils, then they do better. Pulmonary hypertension may also be due to chronic thrombotic phenomena, so you've got to figure out what is the cause of the pulmonary hypertension. The other thing is you live in some odd places, you may actually get sarcoidosis, histiocytosis, and also there's other compression of the pulmonary blood vessels from tumors or fibrosis. Clinical symptoms that you present with any kind of pulmonary hypertension is a person begins dyspneic, or they feel that they're breathless. They develop significant weakness over time, fatigue. They get abdominal distension as well because they're really not getting enough oxygen to the GI tract. And as a consequence, they also develop syncope and they get angina. They get a parasternal lift. You can actually feel the heart is actually underneath the right ventricle begins to hypertrophy. She has actually what's called a parasternal lift. When you put your hand on their chest, you can actually feel the sternum lifting every time the ventricle fires. You hear mitral pulmonary insufficiency murmurs called the Graham-Steele murmur. You get tricuspid regurg because of dilation of the annulus around the tricuspid valve. And you also get pronounced pulmonic component of S2 or an S3 gallop. Again, because this is right-sided heart failure, you're going to get jugular venous distension, liver congestion, hepatomegaly, and eventually ascites. Cardiovascular-wise, you're looking at pulmonary vasoconstriction, vascular wall remodeling, thrombosis. Okay? The right wall stress increases, causing the right ventricle to dilate. Okay? The right ventricle then, the stroke volume begins to decrease, and you get preload reduction to the left ventricle as a consequence to that. And it leads to a decrease in left ventricular cardiac output. The person will develop systemic hypotension. Respiratory-wise, you have a risk for hypoxia by three mechanisms. One is the right-sided pressures begin to increase. Sometimes we'll open up the patent foramen ovale, and then you get basically a shunting effect that takes place. And you also may have a relatively fixed cardiac output with increased oxygen extraction associated with the exertion will produce hypoxemia. And the third reason would be the significant VQ mismatch that takes place. Treatment is unfortunately not really good. Oxygen anticoagulants, if you think that's what's causing it, diuretics. Calcium channel blockers have not been found to be really effective. One of the things that they're trying to use is using phosphodiesterase inhibitors, and now they're actually putting catheters in the pulmonary artery to try to directly affect the pulmonary circulation, not affect the vascular effects of the phosphodiesterase inhibitors, which drop the blood pressure significantly. Inhaled nitric oxide is something that's been considered. Prostaglandins, endothelin receptor antagonists, and surgical treatment have all been tried. Nothing seems to really work. Oxygen therapy can be helpful in reducing the magnitude of hypoxic pulmonary vasoconstriction, so it gives the person a little more time. It gives them a little more comfort, too. Anticoagulation is really recommended because of the sluggish pulmonary blood flow and the dilation of the right ventricle. Okay? Diuretics can also be used if the person is having too much of an increase in preload in the right ventricle, especially with hepatic congestion, ascites, and severe peripheral edema may be present. The only downside to it is you may actually go into what's called hepatorenal failure if you give too much diuretics. The calcium channel blockers is the first class of drug to provide some kind of long-term dramatic benefit. You administer to patients who exhibit positive responses to vasodilator trial in what's called a cardiac catheterization laboratory. You can use nifedipine, diltiazem, and amlodipine are the most commonly used calcium channel blockers but they basically have been shown to improve survival for up to 5 years. They don't really change the prognosis, which is death, and unfortunately. This is not a disease you want to get. Phosphodiesterase inhibitors produce pulmonary vasodilation and improve cardiac output. Viagra has actually been administered and has been associated with improved exercise capacity, reduction in RV mass, and long-term mortality benefits have not yet been shown to be improved. Phosphodiesterase inhibitors inhibit hydrolysis of cyclic guanosine monophosphate, which is cyclic GMP. It reduces intracellular calcium concentrations and effectively causes smooth muscle relaxation. It's effective when given alone and can augment the efficiency of inhaled nitric oxide. Inhaled nitric oxide has no, it basically goes directly and diffuses into the vascular smooth muscle, bypassing the effects of receptor activation. It actually activates the secondary messenger enzyme, which is guanylyl cyclase, which is like adenyl cyclase, but in this case it's in the pulmonary vasculature, and then converts it into cyclic GMP, which then causes a reduction in intracellular calcium concentrations, which leads to relaxation. If you increase cyclic AMP, you actually cause an increase in calcium in the cytosol. But an increase in GMP, cyclic GMP, actually reduces calcium going into, which causes relaxation. So beta 2 blockers are going to be what? Cyclic GMP. Beta 1 blockers are going to be cyclic AMP. Okay? Problems with these drugs is that once you stop taking it, of course, and you have to inhale it, you have rebound pulmonary hypertension. You can get also platelet inhibition because nitric oxide is also a platelet, antiplatelet acting agent. It also will cause methemoglobinemia, which will begin to affect the efficiency of the oxygen transfer. It also forms toxic nitrate metabolites, and the technical requirements for this application is not without its problems. Prostacyclines is an antiplatelet activity, basically systemic and pulmonary vasodilators, improves cardiac output. Complications are, worsening intrapulmonary shunting and rebound hypertension. Administration is continuous infusion and long-term by a pump attached to an indwelling catheter. It can also be given inhaled or intermittent subcutaneous injection. I've seen this used as continuous pumps. They just put it in like a pain pump, and they just leave it in the patient, and they refill it every month. It seems to improve something, significant improvement in cardiopulmonary hemodynamics, at least in the short term, but have not been shown to show a decrease in mortality. But you're making these people more comfortable, which is the trick. You also have endothelium receptor antagonists. They basically bind to two receptors, endothelin A and endothelin B. They cause pulmonary vasoconstriction and smooth muscle proliferation. Endothelin B causes vasodilation via enhanced endothelin clearance and increased production of nitrous oxide and prostacyclin. When you give these antagonists, it improves your PA pressures, lowers your PVR, improves your RV function, and improves the quality of life. And it appears to be decreasing the mortality rate. There's also surgical treatment, which is the RV assist devices can be used to severe pulmonary hypertension. The balloon atrial septostomy is an investigational procedure where they actually put a hole through the atrial septal defect, which allows for right to left shunting to take place to basically decompress the right heart at the expense of an expected and generally well-tolerated decrease in arterial oxygen saturation. It seems to be shown to improve exercise tolerance. These people may need a cardiac and lung transplantation, so this is more of a bridging phenomenon to do this. These cases are very high risk. Okay? Right heart failure can be made much worse with positive pressure ventilation. So things that you got to be very careful with is that any time you put these people under general anesthesia, they may actually have sudden death on you. Okay? So be very cautious. Maintenance of sinus rhythm is crucial. Atrial kick is necessary for right and atrial and left ventricular filling. Newly diagnosed, administer your drugs appropriately. Okay? Long-term vasodilator must have the therapy continued, not stop their medications. Okay? Systems for inhalation of nitric oxide or prostacyclin should be immediately available. So this is really for a tertiary referral center. This is not something that should be done in a little hospital unless you have all this equipment available to you. Okay? Sedatives can be used with caution because respiratory acidosis may actually increase the PVR. Anytime you sedate these people and you increase their CO2 levels, you actually make this vasoconstriction get worse. So opiates, pentothal, depolarizing or non-depolarizing, may be used safely, but the biggest problem is when you use the opiates post-op again is it causes hypercarbia. Ketamine and etomidate may suppress the mechanism of pulmonary vasorelaxation and should be avoided. This is one of the few contraindications to using etomidate. Epidural anesthesia has been useful for patients that are having a C-section, but again, you have to watch your intravascular volume, especially after the baby's been delivered. Okay? Remember that prostacyclines and nitric oxide can inhibit platelet activation, and the level of regional anesthesia should be reduced slowly with invasive hemodynamic monitoring. Central venous monitoring is recommended to avoid disruption of sinus rhythm, of course, and intra-arterial blood pressure monitoring is also recommended. Maintenance, it's basically the inhaled anesthetics are safe. The only thing you want to consider is watching that nitrous oxide, which may actually cause some vasoconstriction in the pulmonary heart and cause pulmonary hypertension to get worse. Avoid the histamine-releasing drugs, which also will cause pulmonary hypertension. So all your benzoisoquinolone should be avoided. Atracurium is not a good choice, in other words. Hypotension can be corrected with norepinephrine and phenylephrine, okay, and fluids. Should severe pulmonary hypertension develop, use of the phosphodiesterase inhibitors like milrinone. Consider nitroglycerin, nitric oxide, which is nitroglycerin breaks down into what? Nitric oxide, okay? And prostacyclins. Okay. Postoperative period, the risk of sudden death in the early postoperative period is due to worsening PAH. Okay, it could be from pulmonary thromboembolism as well as dysrhythmias. You monitor these people very carefully, and they really shouldn't be sent home until the person is really back to their normal state. Obstetric population, you're looking at forceps delivery. It seems to decrease the patient's effort is recommended. Nitroglycerin should be immediately available at the time of uterine involution because of the return of the uterine blood flow so high. So make sure that you have nitroglycerin.